Speaking of physicians and the physician ego and workflow,
Yeah.
how have you addressed that in terms of getting providers behind the idea of using this and the benefits of it to, clinical quality,
Sure.
efficiency, patient safety, patient outcomes?
Well, I think the most important thing on that front is to understand that why physicians went to medical school in the first place. They care about patients. Even if they've themselves forgotten it at times, there's a heart in these clinicians that you need to reach out to. We've done that by focusing on patient safety as the primary reason why we're doing these projects. In organizations that fail on these large clinical transformation initiatives, they usually fail because they have not made that case in advance. And so I'm asking people for more of their time. It's an investment in time. It's not easy work. And then even if they invest their time to help us get started, it's a change in their workflow, so there's a learning curve. So if they don't understand why we're doing it, and they don't believe that we're doing these projects for patient safety, they really won't engage. They're not making more money off of this. In fact, they're losing time. Mistakes I've seen made on sort of marketing these projects is overly focusing on government regulations, meaningful use, federal mandates. Particularly in states like Texas, you can't lead with a federal mandate. You're giving people a reason to walk away from the table and feel pretty good about walking away from the table. There's the reason these are federal mandates, the reason meaningful use exists, because these are good things for patients if they're done correctly and done well. And so that helps capture the hearts of our physicians. How we integrate with them and engage them intellectually is really using a couple tenets on one, we don't waste their time. So I try to avoid the massive steering committee and subcommittee infrastructure that has
Meetings.
that has a lot of doctors in a room together who don't like each other or have a competitive business interest that will actually, again, give them a reason to walk away from the table. So we do a lot of one-on-one engagement. We meet physicians on their terms, in their office, in their workflow, to get input on how they do things. And then we do our homework. So we study how they take care of patients now in the current state or before we do these projects, so we can kind of better understand what they're going to feel comfortable with and what's going to be a big change for them. That means when we do have the meeting, eventually we have to have a steering committee or we have to have a meeting with more than one physician in the room. We've gotten 80 or 90% of the way there because of the homework, the one-on-one engagement. We get people to agree without making them acknowledge that they agree.
Diplomatic.
It's really used all these political strategies because at the end of the day, the physicians don't really have that much variation on the evidence-based elements of care. They tend to disagree or grind on more logistical elements of care, things like the timing of labs or the certain non-evidence-based nursing interventions that they feel are important for their procedure that maybe they disagree with their partners on, but nobody disagrees on stopping the antibiotics 24 hours after the surgery, which is an evidence-based element.